Today we have a very exciting topic, and we're privileged to have a very exciting visiting professor join our panel. The topic is asymptomatic incidental hypertrophic cardiomyopathy. As I expressed earlier, I wanted to give my personal appreciation to Dr. Maron for changing his schedule and his plans. He initially was going to join us in March, and he changed it because of unforeseen circumstances on our part to January, and we appreciate it. One of the other comments I made is that a father is always inspired and gratified when his son doesn't rebel too much, let alone follow in his footsteps. And here we have an example where probably one of the most foremost experts in a particular field, Barry Maron, has the honor and privilege of mentoring his son, Martin Maron, who's here today in the field and who may well have exceeded him, his own father, in prominence, to the point where usually the son follows his father in the same institution. I hope I'm not embarrassing you, but Marty took an opposite path. He took an opposite coast, developed his own center, and made it so unique and distinct that his father came to join him. So it's really a distinction and an honor and a privilege that he came today. And again, I appreciate the fact that you changed your schedule, and his wife hopefully won't be delivering during this session. So just to tell you about the upcoming attractions, we have a fantastic second half of this season led by Dr. Maron today. In February, Harlan Kromholtz from Yale. In March, Dr. Scott Gottlieb from the FDA. April, Glenn Fishman from NYU. In May, Dr. McCrae from the Brigham and Women's. And in June, Dr. Robert Califf, formerly of the FDA, formerly of Duke, now back at Duke. This topic is incidental asymptomatic hypertrophic cardiomyopathy, is something which we face all the time when we're seeing patients, and a very tough topic, actually. And David Narodsky has put together a very nice monograph that he's going to summarize now in a few minutes. David?
Thank you, Dr. Goldman. Thank you, Dr. Maron, for joining us, Dr. Fuster for moderating, and everyone who will be on the panel and in the audience, thank you as well. So I'm going to summarize a little bit. Dr. Maron did an excellent job of reviewing this today, but I'll go through it a little bit again now for everyone who couldn't make it and just as a springboard for a later conversation. So hypertrophic cardiomyopathy, it's a genetic cardiac disorder. It's characterized by left ventricular hypertrophy. It's primarily asymmetric hypertrophy, most severe and most often in the basal interventricular septum. The clinical diagnosis can be made by visualizing it on echo or cardiac MRI with a wall thickness of 15 millimeters or greater in a non-dilated cavity in the absence of other causes of LV hypertrophy, such as prolonged systemic hypertension, aortic stenosis, or other metabolic disease. Milder LV thickness, 13 to 14 millimeters, can also be considered diagnostic in patients whose close family relatives have HCM. And in children, the diagnosis requires hypertrophy greater than 2 standard deviations from the population mean. HCM is not an uncommon disease. Prevalence of about 1 of every 500 people, or 0.2%, although with better imaging with cardiac MRI and genetics, it's probably closer to 1 in 200 people. In most people, it's an autosomal dominant trait, most often due to 2,000, although I heard today 2,500, so I guess the number is changing by the moment, and at least mutations in at least 11 cardiac sarcomere genes, and most of them are in myosin proteins. The phenotype of the disease can actually change by the site and extent of the hypertrophy, as well as associated abnormalities, and these often include a dynamic left ventricular outflow obstruction, diastolic dysfunction, myocardial ischemia, mitral regurgitation, and arrhythmia. So a little bit about the natural history. So HCM has somewhat inaccurate reputation as an unrelenting disease with a poor prognosis. It doesn't really factor in diagnostic and therapeutic advancements. Currently, the mortality is similar in HCM patients as that to the general population. And for most patients, the LV hypertrophy is not progressive, they remain asymptomatic. Some patients, however, present with severely limiting symptoms such as dyspnea, angina, palpitations, and presyncope or syncope. HCM has largely been characterized in the past as resulting from dynamic left ventricular outflow tract obstruction, and it's been referred to in the literature as HOCM, or hypertrophic obstructive cardiomyopathy, or IHSS, as idiopathic hypertrophic subaortic stenosis. The focus stems from the classical clinical presentation of heart failure symptoms that are related to dynamic subaortic gradients, either at rest or provoked. Yet many patients, 1/3 of them, do not express these gradients. Dyspnea and angina in these patients and others can occur in non-obstructive patients due to other mechanisms mentioned. In fact, in a contemporary study, 90% of non-obstructive patients with class 1 or 2 NIHA symptoms moved to class 3 or 4 at a rate of 1.6% per year, compared to patients who are obstructive who progress to heart failure 3.2% per year, double, and those with a rest gradient at 7.4% per year. So of these obstructive patients who advance quickly to advanced symptoms, 90% improved following relief of the subaortic gradient by an invasive procedure, showing that the obstructive patients have a more predictable clinical course and better treatment. There was a subgroup of these non-obstructive patients in this study that were refractory to medical management and proceeded to transplant evaluation. And these are some of the patients that we may want to focus on today. So part of the diagnostic evaluation for left ventricular hypertrophy. So the exam in patients with HCM is often normal. An outflow tract obstruction may present with typical findings such as Bisphereon's pulse, systolic ejection murmur that radiates, and that's infected by maneuvers that affect preload and afterload, such as standing from squatting, Valsalva. Also, that's associated with mitral regurgitation. The EKG in patients with HCM is abnormal in 90% of patients. There's no one pathognomonic pattern. However, we often see prominent voltages with LVH and strain patterns of ST wave changes or T-wave inversions, often in the anterolateral leads. Pathologic Q waves may be present as well. On ambulatory ECG monitoring and Holter monitoring, we frequently see SVTs and NSVTs. On echo and CMR, we first used echo as the diagnostic modality. We measure LV, the maximal LV wall thickness, in the parasternal long or short axis planes from base to apex. We often need dedicated parasternal and multiple apical views to be obtained to detect apical HCM, and apical HCM is also better characterized with contrast echocardiography. If the echo views are inconclusive, cardiac MRI should be performed, especially if the LVH is localized to the anterolateral wall, the apex, or the posterior septum, which are difficult areas to image on TTE. It also provides for tissue characterization like we were speaking about earlier with late gadolinium enhancement, which can assist both in diagnosis and risk stratification. Patients with HCM or LV hypertrophy should be investigated for outflow obstruction, as these may be candidates for other therapies. It's defined by a gradient of 30 or greater than 30 millimeters of mercury at rest or during physiological provocation. Above 50 millimeters of mercury is usually considered the threshold at which hemodynamic obstruction becomes significant. And symptomatic patients with this kind of gradient do not need exercise testing as a provocative measure and probably should proceed to therapy. The difficulty is in asymptomatic patients. So in those patients who mount an exercise gradient greater than 30 millimeters of mercury, they should be followed longitudinally. They're more likely to advance. So the differential diagnosis can be difficult with purely LV hypertrophy on the ECG and kind of ambiguous symptoms. Other symptoms that can mimic it are due to LV hypertrophy caused by pressure overload conditions such as systemic hypertension or an athlete's heart. So clues for HCM include asymmetry and a small cavity size. For example, in an athlete's heart, there's a contrast because the LV is usually large and the diastology is usually normal. These patients on CPET also perform better. Another mimic is that in elderly patients, they frequently express isolated basal septal hypertrophy. And other phenocopies include infiltrated diseases such as amyloid, Fabry's disease, Danon, and Noonan syndrome. And they usually have different typical imaging characteristics on echo and MRI. Family members who've been screened positive for a disease-causing mutation, who are referred to as the category of genotype positive, phenotype negative, may have subtle structural abnormalities that are clues that they may develop HCM. The likelihood of finding a disease-causing mutation is highest in patients with familial disease and classic clinical features. And the first step in genetic screening involves the family pedigree, especially asking questions about family members with sudden death, unexplained heart failure, or the need for transplantation, or pacemaker or defibrillator. There is still an unclear relationship between the phenotype and the genes involved. Atrial fibrillation is the most common arrhythmia in HCM, with a thromboembolic annual incidence of 3.8%. And that's why the major guidelines, the AHA-ACC guidelines in 2011 and the European Society guidelines in 2014, recommend anticoagulation for all patients with HCM who express atrial fibrillation, regardless of the CHADS-2 VASC score. And finally, the risk stratification for sudden death. So the annual incidence for cardiovascular death in HCM patients is 1 to 2%. Sudden cardiac death is the most common cause, followed by heart failure and thromboembolism. The most common lethal arrhythmia is ventricular fibrillation, and ICDs have been shown to be effective at preventing sudden cardiac death and prolonging life. Clinical features associated with sudden cardiac death and used as indications for ICD include prior cardiac arrest or ventricular tachycardia, a maximum LV wall thickness of 30 millimeters, a first-degree relative with sudden cardiac death, unexplained syncope, and other potential markers, including non-sustained ventricular tachycardia or abnormal blood pressure response to exercise. For intermediate patients with either 0 or 1 of these traditional risk factors, other parameters are also considered, including the extent of myocardial fibrosis on MRI, the presence of apical aneurysms, and the inheritance of multiple sarcomeric mutations. An uncommon variant of HCM, which we see clinically, involves apical hypertrophy of the LV in Yamaguchi syndrome. These patients may have a midventricular obstruction and are typically lower risk for sudden cardiac death unless associated with an aneurysm. And with sports screening, HCM is the structural heart disease most commonly associated with death in the US athletes. It accounts for up to 36% of cardiac events. Therefore, all major cardiology guidelines recommend against participating in competitive sports in patients with HCM, regardless of whether an obstruction is present. Thank you.
Good job, David. Very good job, actually. In a very complex disease, I think you have a fantastic summary. Well, anyway, it's a pleasure today to introduce our visiting professor, Dr. Martin Maron, who was trained, well, he went to college at Johns Hopkins, and then he moved to Tulane University, where he obtained a medical degree. He had his internal medicine residency at the Washington University School of Medicine in St. Louis, and then he had his cardiology fellowship at Tufts University, and he never left there. He has been in Boston certainly since 2004. He did some training in imaging, specifically in magnetic resonance imaging, and he has been a tremendous, I would say, a pioneer in the field of hypertrophic cardiomyopathy. His father was fine, but the son is fantastic. You just have to see the publications that he has as a first daughter. Actually, I will begin by saying he has a number of awards. One when he was at St. Louis, then he was the Best Poster Award for magnetic resonance imaging, and recent competition, and so forth. I think what is most striking in his curriculum are the publications, which is, the way an academic person today is being rated is by how many grants you have, particularly from the federal government, and the second, how many publications you have in high-impact journals. That's the two things by which people are being rated, and he's top in this. He has about 150 publications, despite of his relatively young age. And the first publication was in 1994 about the prevalence of hypertrophic cardiomyopathy in an outpatient population. We'll talk about this in a moment. And the last publication is interesting, just in the American Journal of Medicine, and is entitled Non-Obstructive Hypertrophic Cardiomyopathy Out of the Shadows, known from the beginning, but largely ignored until now. Well, we are going to talk about this, and I must say, to address the issue properly, you can do it in many, many ways. One, you do it in a didactic way, then will be a book chapter. Doesn't work. So what I'm going to do is to, first of all, give thanks for you visiting us. I will give you a plaque. At least you will remember your stay here today. And then we'll go into the subject, touching into the issues that I think are most interesting and rather new. Well, thank you very much for visiting us. You have a lot of expressions in this plaque. This one is wrong, says March 19, but you accept it. Okay, you're ahead of our time.
Right.
All right, so our group give you this plaque for the outstanding teaching, wisdom, and expertise as the Nandi Sharma Visiting Professor in the Simon Duck Memorial Lecture. Thank you very much.
You.
Yeah, very nice. How did you get the plaque? You did the picture already, Martin? You already took the picture? Good. Hey, you forgot the chair.
Oh, yeah.
Thank you. Anyway, so let's begin. You sit in the middle.
Okay.
And there are so many experts today here. Let me start by one. Amy, Mark Miller, Shinpini, Javier Sanz, and of course David. Do I miss anybody? No. Well,
Donna Mancini instead of...
oh, I'm sorry. Donna Mancini. Donna, I'm sorry. Where are you? All right. Good. So let me begin by asking a couple of questions. Martin, question number one. This is a genetic disorder, but in only 60% of people you can trace the genetics going backwards. What's happening?
I have no idea. I really don't. As far as why do almost half the patients with a clinical diagnosis of HCM have no mutation identified? Yeah, so, look, I think the question of why do half of all patients who have a clinical definition or diagnosis of HCM have no mutation identified is unclear right now, and an area of a lot of active investigation. My understanding is that the sarcomere has been sequenced. It's not as if we're missing mutations, and therefore it's not clear how to explain the basis for that half of the population.
However, it is transmitted. You find the gene or you don't, but it is transmitted 50%. Is this correct?
Correct. That's exactly right.
Autosomal dominant. Amy, do you have any answer to the problem? Why 60%? Why 40% of people, they come with a hypertrophic cardiomyopathy and we don't have any idea where it comes from?
So I think there's two parts to the answer, two possible parts. One is that this type of disease is characterized by very variable penetrance. So there may be relatives who are carriers of some unknown or unyet identified mutation, and they may not have had a fully penetrant disease in their lifetime. And so there may be other relatives who are genotype carriers, genotype positive gene carriers who just weren't identified. And the other possibility is that the panel testing for HCM includes maybe 62 genes at this point, but they're not all hypertrophic cardiomyopathy genes. Only about 11 or 12 of them are specifically linked with HCM, and there's probably other genes that are implicated that we just don't know about yet.
And the epigenetics and all this stuff, that we'll talk about these later. Just try to, I have a second question, Martin. You say this is one of every 200 people that show in our outpatients have hypertrophic cardiomyopathy. This may be in your house, but not everywhere. I mean, this is 1 in 200 is very high. Is this because we miss them, or is because this data comes from selective groups that look at this disease specifically?
Yeah, well, so the 1 in 200 is a prevalence of HCM. If you literally took people off the street and you image them, 1 in 200 to 1 in 500 would meet the clinical definition. That's the prevalence of the disease that we believe is in the general population. Now, that number is different than the clinically identified patients. That's a group that's much smaller. In fact, we think it's a lot smaller. It's probably about 10% only of the entire denominator of patients that are affected with this disease get identified clinically, perhaps because overall, it's actually a really benign disease, and the vast majority of those patients with HCM never have an event or a reason to become clinically identified, probably.
David, today you're a real expert in the field. There's something surprising to me by going over all this literature, and that is if you have 100 patients properly diagnosed with hypertrophic cardiomyopathy, it turns out that 30% they don't have a gradient at all. 30% they only have a gradient if you exercise them, and 30% is the so-called IHSS. Is this surprising to you? I mean, when I was in training, everything was IHSS. I don't even remember people talking about non-obstructive hypertrophic cardiomyopathy. So what has happened here?
So like you mentioned, actually, I think the history is really important and the tools we have in diagnosis. Initially, when we were thinking more about dynamic subaortic gradients, it started more in the 1970s because the cath lab was the catheterization was the tool we had. And now with really advanced imaging, we're able to better detect people who meet the imaging criteria of the wall thickness, but don't really have the full spectrum of the obstructive outflow gradient. Now, we know that the non-obstructives do a little bit better, so is imaging it irrelevant? Not really, because a small percentage do progress to pretty advanced heart failure, and we still need better ways to figure out why that is if it's not caused because of an outflow obstruction.
Okay, so I'd like to get Martin into one question, and this is a paper which you just published, and it's about the natural history, which is actually today the topic is asymptomatic hypertrophic cardiomyopathy. You just published the paper. If you don't mind, I will summarize it just in a couple of minutes. Mm-hmm. This is an interesting paper which is entitled The Natural History and Management of Non-Obstructive Hypertrophic Cardiomyopathy. But basically, they had close to 500 patients with hypertrophic cardiomyopathy. And when you look at about 30% actually were obstructive, they serve as controls. And the other 30%, they have a gradient, they didn't have any gradient at rest or on exercise. And one group had a gradient on exercise, but not at rest. So 50 to 70% were non-obstructive, but with exercise they were. And the data is the following. In terms of symptomatology, most of the patients who were non-obstructive, and I'm talking about at rest or on exercise, they had symptoms class 2 or 3, class 3 or 4, only 1% per year, 1.6%. Those who had obstruction with exercise, basically you exercise and you get a gradient of about higher than 30 to 40 millimeters of mercury, isn't it? Mm-hmm. And 3% develop per year develop symptoms class 2 or class 4, where patients who had obstructive cardiomyopathy from the very beginning at rest and on exercise is 7%. So it seems to me that there's a large number of patients with hypertrophic cardiomyopathy which is non-obstructive, and actually they are very free of trouble, about 70%, practically asymptomatic.
Yeah, I mean, so I think the message, there's a couple messages here. One is that, we have promoted with these data the idea that that exercise echo really is the key test here, because you've got 2/3 of patients with HCM that come to you without any evidence of outflow tract obstruction. And there's really no way to proceed forward with managing these patients really in the right way without identifying whether or not they have obstruction with exertion. And there's been historically, as I talked about this morning, a lot of different ways of provoking gradients, Valsalva, dobutamine. A lot of those are they're all non-physiologic. And the significance of provoking kind of gradients with these kind of maneuvers or drugs is really kind of remains uncertain in a lot of respects. And so it was the opportunity to apply a physiologic test like exercise echo that allowed us to really put patients with HCM in the right kind of hemodynamic category. If you've got rest obstruction, you don't need to exercise because you already know the basis for symptoms. It's the obstruction. And then you take this large group of 2/3 without obstruction, you apply exercise echo, and you can reliably then determine whether a patient is developing gradients with the normal daily activities that the exercise echo is essentially trying to mimic. By doing that, you then separate them and you get them in the correct category. Non-obstructive truly, the third with provocable, and the third with rest obstruction. That allows you to do two things then. One allows you to define better the natural history for those patients, because if you've got provocable obstruction, you're much more likely to develop limiting symptoms than the non-obstructives. And that's important for patients to understand and know. And two is that if a provocable obstructed patient does develop limiting symptoms at some point, you've opened up treatment options for that patient that are not available to non-obstructive patients. Surgery, ablation, and for that matter, drug therapy like Norpace, which is a negative inotrope. So that's really was one of the major sort of points about that study, is that there had not been a focus really on the non-obstructive natural history, because largely, historically speaking, the focus in HCM over the last couple of decades, rightfully so, had been on the very visible component of obstruction, because it was something that could be treated. So with this exercise echo data, we were able to show, one, what happens to the non-obstructive patients, which fortunately is that very few develop limiting symptoms. The problem with the non-obstructives, though, is that the small number that do develop advanced heart failure, that's a really challenging area because we don't have a lot of great drug therapy. And the only long-term option for most of those patients, as they're often young, is heart transplant.
So can I ask, it seems to me that 70% of patients with hypertrophic cardiomyopathy, at 10 years of follow-up, the survivorship is 95 to 97%. So it's amazing, isn't it?
Yeah.
Now, the question is, Amy, these 10% of patients that he quotes the paper that actually go into trouble with the non-obstructive, just 10% as he mentioned, why do you think they go into heart failure? Could not be these kind of mutations that can affect, the so-called hypertrophic cardiomyopathy, but they are mixed with the dilated cardiomyopathy. Actually, I remember 2 patients who went to transplantation, patients of mine who actually they were completely classic for hypertrophic non-obstructive cardiomyopathy. It went into ejection fractions of 20% over a 5-7 year period. What do you think is happening?
I haven't seen those cases myself. Those might be the compound heterozygote cases and the double mutation cases where there could be a sarcomeric mutation that's causing the hypertrophy phenotype and then maybe another mutation that can contribute to a dilated phenotype.
Martin, you agree with all of that?
Well, yeah, so when you look at the non-obstructive patients with HCM that get into trouble, this 10% that develop advanced heart failure, a couple things. One, about half have preserved EF, 50, 55, 60, 65%. And the other half develop end-stage HCM, the so-called burned out phase of the disease, where we define that in HCM as EF of less than 50%. Oftentimes there's remodeling that comes along with that as well, with cavity dilatation and wall thinning. So the end-stage heart failure picture in HCM is uncommon, but is usually either about half with preserved EF and half burned out. The reason that they go into the burned out phase, or for that matter, get heart failure with preserved EF in non-obstructive HCM, is not clear. I don't think that there's any clear relationship between specific types of mutation and that risk. it's probably multifactorial. We say it's always diastolic heart failure, which is probably a contribution of fibrosis, abnormal myocardial blood flow from bad small vessel disease, again, decreased compliance from scar, and it ultimately, in both groups, results in a low output heart failure.
Okay, so these were general issues to discuss, the natural history, which works with obstructive, the non-obstructive, with some exceptions. Let's now move into imaging, because in imaging there are 4 different eras, and there are actually 10 different patterns that I would like to discuss here, just to show how complex and heterogeneous is the disease. So the 4 eras, let me ask Steve, you were there, between 1950 and 1960, as pointed out by David, what we learned was the pathology and the hemodynamics, and this actually pretty much happened at NIH, if I recall. How hypertrophic cardiomyopathy was described by Brownwell and others. Then in the 1970s, M-mode echocardiography provided a lot of information. Is that right? With the thickness of the ventricle, and then the systolic anterior motion of the mitral valve. I still remember being a fellow, and this was like the 2 issues that actually M-mode echocardiography really became one of the aspects that became so popular because it was quite specific. And then we have in the 1980s Doppler, which, quantifying the situation of obstruction, quantifying mitral regurgitation with the outflow gradients. And then we have a fantastic display of technologies here with 3D ultrasound, CMR, and CT imaging. Do you think that at the present time we have all what we need, because we will go over 12 patterns, 10 patterns. Do you think we have all we need in terms of imaging to really arrive to some conclusion of what we are talking about?
Well, I think we could always use more imaging, but I think that the things that we have are very good. M-mode, even now, still provides lots of information because of its very high temporal resolution for certain things across the aortic valve, and as you said, the systolic anterior motion of the mitral leaflet. I think the fact that echo can provide very good hemodynamic measurements for most patients in conjunction with exercise stress testing, like Dr. Maron was talking about at noon and just now, make it an invaluable first-line imaging modality. And then I think Dr. Sands is here. I'm sure he can talk about cardiac MRI and CT. I mean, the resolution that we can achieve now with these modalities are amazing.
Okay, so let's begin. Let's begin with Dr. Sands, Javier. Let's begin talking about the left ventricular obstruction. How confident you are by using MR or CT that you can get the data, or you think that actually is going to be Doppler echocardiography much more accurate? We are talking about the degree of obstruction.
Yeah, it's going to be Doppler. So with CT, you cannot really get it. I mean, you could see some morphologic issues or aspects, like, for example, mitral systolic anterior motion. You can see that sometime. With MRI, you can get a velocity measurement, but I think Doppler is more accurate and it's probably more reliable in general. So that's not something that we typically do with MRI unless there's a question. But I think Doppler would be the winner there.
Okay, so we have now the Doppler, and I'd like to ask you, Martin, you have a Doppler that at rest you have a gradient of about 25, 30, and you still call these non-obstructive, I believe. And then you exercise the patient with echo Doppler and you get a gradient of 60. How do you react to that?
Well, so yeah, let me just clarify a couple things. One is that we typically define obstruction as 30 millimeters of mercury or more, because you need, for the mitral valve, when it touches the septum and impedes flow, will give a patient at least 30 millimeters of mercury extra pressure in the LV. And so that's where this 30 millimeter or greater cutoff came from. The feeling, though, has been that in order to move forward with, for example, invasive options like surgery or ablation, that patients really, we should demonstrate in patients that they have a 50 millimeter mercury or greater gradient, either at rest or with exercise, because we want to be sure that we're connecting up the symptoms with a gradient. So there's been a little confusion about that, I think in general in the literature. And so that's sort of what the history is behind those two numbers. Sure.
Donna, you have a comment?
In terms of
Can you speak a little
the
louder?
exercise test,
Yeah, thanks.
do you also detect who develops pulmonary hypertension?
Well, we look at pulmonary hypertension as well at rest and with exercise. And I think that in summary with that, most patients with HCM have some degree of pulmonary hypertension. The impact of that on symptoms is unclear because what we see is that when you relieve the gradient, that the pulmonary hypertension for almost all patients will slowly come down over time, will get better. And that we know that when you relieve gradients clinically, patients will then achieve a class 1 or 2, even if they have a little bit of mild or even sometimes moderate pulmonary hypertension that's residual. So the feeling then is that, it doesn't seem, at least from a clinical view, that pulmonary hypertension itself is contributing independently substantially to functional limitation here.
But don't some of these patients develop irreversible pulmonary hypertension?
So the non-obstructive patients can develop irreversible pulmonary hypertension for sure. There's no question about that. And so that's why, we really have to be diligent at, getting these patients potentially listed earlier than I think they're generally being referred for listing, because I think there's this perception that that they're generally non-obstructive and then okay, even if the patient has some symptoms, when in fact, the reality is that what we find is that once they come to us with really advanced heart failure, non-obstructive, that the pulmonary hypertension may be irreversible at that point, and then they don't become candidates for transplant.
Okay, Javier, I'm sorry. Let's leave the obstruction for a moment. Later on, we'll come to the obstruction, whether you disobstruct to prolong life, but that's a different issue right now. Javier, at least what I have learned over the last year is that if you want to quantify mitral regurgitation, there's nothing better than MRI. Are you in agreement with that? And does this apply to this particular entity that we are talking about? Quantify.
Oh, that's a tough one. So the methodology that we use to quantify mitral regurg with MRI is, in theory, very accurate, but the problem is how do you validate it, what do you compare it with? And the validation is typically done with echo. And when there are disagreements between the echo and the MRI, it is difficult to know if one or both are wrong or right, because it could be also that the mitral regurg is changing from day to day. So specifically in hypertrophic cardiomyopathy, I think one of the advantages that MRI would have is it doesn't matter whether the jet is eccentric or central, or you have more than 2 jets or not, because we basically compare the stroke volume from the left ventricle from the volumes to the stroke volume that leaves the aorta, and the difference should be the mitral regurgitation volume. But again, can I really state that this is the most accurate method? I don't think we can.
Thank you. Okay, so let's move into the septum. Now, another surprise to me, at least, is that we all talk, at least in medical school, this is a focal disease that is the basal part of the septum is hypertrophic. It turns out that 50% is concentric. Martin, is this correct?
Well, in HCM, it depends on sort of what era you're looking at this disease from. There was this, there's this principle that with 2D echo, that about 1 to 2% of patients with HCM had truly concentric hypertrophy, which was defined as 1 to 2 millimeters, no more difference than about 1 to 2 millimeters between the wall thickness in the septum and the posterior lateral wall at the basal level. And so it probably is true that you can have concentric hypertrophy with sarcomeric HCM, but it's really uncommon. It's a very small number of patients.
Okay, a few questions about the septum. First of all,
Yep.
we talk about the thickness, and at least I remember a couple of cases in which an echo came from outside, hypertrophic cardiomyopathy, and the people here said this is the crista supraventricularis. Apparently, the right ventricle can give you a false picture of the thickness of the septum.
Right. So one of the observations is that echo can sometimes overestimate wall thickness compared to CMR or MRI. And one of the reasons that that's the explanation, the most likely reason that that's the explanation, is that there can be RV muscle structures, this so-called crista supraventricularis. It's an RV palpable muscle structure, which seems to be also part of the disease process in HCM because it can be thick, and at the basal level, it looks like it sort of inserts onto the basal anterior septum, even though it's an RV structure. And therefore, essentially, it's difficult to differentiate that structure from the ventricular septum. And with MRI, because it happens to be a higher spatial resolution technique, it's easier to see that muscle and to exclude it, which it should be. It should be excluded from the ventricular septal measurement. So that's why I think one of the reasons that you sometimes see wall thicknesses that are overestimated by echo when you look at the MRI images is because of the inclusion of that crista muscle in the echo wall thickness measurement.
By the way, it seems this is not infrequent, isn't it?
No, I think it's probably, no, I don't think it's infrequent. I think it's one of the problems. And that's one of the cases that I think can be made for MRI. You know, I mean, that's why I think it's a multimodality imaging disease, is the MRI can help overcome that particular issue and therefore provide, you know, really reliable, perhaps the most reliable measurements of wall thickness.
Donna, I have 3 patients with 3 different thickness of septum. See what you think. The first one is an 18-year-old that has a thickness of the septum of 16 millimeters, and he's an athlete, but he's a young athlete. He's a what? 18. Athlete. Yeah, just 16 millimeters, and he's a young person, age 15. Second, age 15, 16. Second individual, here you have a hypertensive guy who has a septum that is about 14 millimeters, okay? And let's talk about these 2 people. What do you think?
I would be more worried about the 15-year-old with the thick septum than the hypertensive 40-year-old guy, because I'm not sure the other guy has hypertrophic cardiomyopathy or just hypertensive heart disease.
I try to put the age into the discussion because many times we get obsessed about millimeters and we don't realize the age. For example, you have a Fabry's patient, which can be completely, you can be not sure, but it's a very young person, where patients with a high HSS or hypertrophic cardiomyopathy are in the 30s is not correct. I mean, the age in patients with amyloid, for example, we face this all the time. So what I was going to ask is not only the septum. Martin, what size of septum you really get worried about? 15 millimeters, like going from then on? We cannot be dogmatic as we discussed, but...
Right. Well, yeah, I mean, I think 15 millimeters or greater without another explanation is concerning enough that additional workup or consideration to HCM should be made. And wall thicknesses that are a little bit less than that, 13 or 14, in a family member of a patient with HCM, you know, also worry us because that starts to suggest that they may be within the spectrum of a clinical diagnosis of HCM as well.
Okay, now maybe Dr. Liao, I see so many reports here in this place of chordae tendineae that they go from the wrong place to the wrong place, you know, papillary muscles, and then you don't know if you're hypertrophic cardiomyopathy, if you're obstructing or not obstructing. What in the world is all of this? The infrastructure of the mitral valve maybe fooling you. Maybe the patient may have hypertensive heart disease, but then we see all these bundles crossing. What that means?
It's true. Dr. Goldman and I were discussing this earlier today. I mean, we do see very frequently aberrant muscle attachments to the septum. Dr. Maron presented a case where it was attached to the anterior mitral leaflet as well, and then moderator bands or on the right side. I don't really know what it means or the underlying reason why we see these things, but we do see them more frequently, especially with the imaging technology getting better, resolution improving, we tend to see them more commonly now. And then in our lab, we use a lot of echo contrast, so this kind of brings it out even more in the studies that we're performing recently. So I don't really have an answer, but it is not an uncommon thing that we see in the echo lab. The clinical significance, certainly we don't want to be calling these aberrant muscles to be a hypertrophic cardiomyopathy, but sometimes it can be tricky to figure it out, and I think sometimes cardiac MRI will be helpful in those situations.
Martin, I reach a conclusion. We see this so often. I reach a conclusion. There is no sum I disregarded. What do you think? In other words, all these papillary muscles that you think are affecting the mitral valve, without a sum, do you think this means anything?
Well, I mean, I think it could. I think, as we're saying, I think it could, even in the absence of SAM, if there is mild hypertrophy with the presence of evidence of valvular mitral valve or submitral valve abnormalities. These are often accessory muscle bundles, direct insertion of the papillary muscle directly into the mitral valve, elongated mitral valve leaflets. All of those things, the right side, the crista, all those things can help sway potentially toward a diagnosis in a patient with mild hypertrophy, even in the absence of SAM.
Okay. So I have to go back and think again.
Well, yeah. I mean, I think again, they don't say that it's I'm not saying it's a definite, but I think it adds weight.
It's just it's so common. The patient is hypertensive, has some hypertrophy, and then you see all these bundles crossing.
Right.
And with and the question is what it is.
Right. Well, yeah. I mean, I think it can be challenging. I think you have to take the whole clinical picture, obviously, into consideration at that point. That's an ambiguous area.
I have another question for you. Mark Sherritt is quite obsessed about one issue. He thinks that the leaflet of the mitral valve is large, and this is part of the obstruction. Is this a genetic disorder that goes on with a large leaflet contributing to some?
Well, so a couple points on that. So it is true, and we've made this observation too, that the mitral valves are elongated often in HCM. Sometimes they can be really long. And I think that I don't know why that is. There's no myocytes in the valve, as I was saying this morning, and it starts to raise the idea that there may be some congenital or embryologic aspects to this disease that explain some of the features outside of the LV wall, hypertrophy, like the mitral valve, like the anomalous insertion of the papillary muscle directly into the anterior leaflet. Those start to speak to me of a congenital embryologic issue to some degree. Clinically, the anterior leaflet being long can contribute to obstruction, meaning it's one of the promoters of obstruction because when the leaflet is long, its exposure into the outflow is greater and therefore it can be pushed into the septum with high flow in a narrowed outflow tract. That doesn't mean that all patients with HCM who have obstruction have a long leaflet. It just means it's one of the issues that when present makes it more likely to have obstruction. And when the leaflet is really long and you have an obstructed patient, to me, that's one of the distinguishing features about whether an ablation, alcohol ablation, or surgery should be considered, because often you can't rid the patient of obstruction completely with alcohol ablation only when the anterior leaflet's really long. And that's a patient that, in my view, perhaps should have a myectomy with a anterior leaflet shortening called plication. So those are the some of the implications related to the valve in HCM.
Okay, and I'm sorry to get to you because you wrote an article. I have a friend who I saw as a patient with an apical hypertrophy and had some degree of aneurysm. And very happy, Holter negative, doing very well, and then ended up reading your article, and he thought he was dead.
I hope he's not, by the way. I hope he's still going.
He's alive, actually.
I
But
get it. I hope he's still
the
going.
question is, you point out that an apical aneurysm, even if it is not very large, could be a cause of arrhythmias, of decompensation, and thromboembolism, and certainly sudden death. And the question is, when I read the percentages, I was not very impressed, frankly. I mean, it may happen, but the way I read it, and I don't recall, is about 2% per year or something like this. And, what do you do? We see these people.
Yeah. Yeah, and so what we're talking about here is that, and let me just make one point about nomenclature. Apical HCM has traditionally referred to hypertrophy confined to the apex, often limited and focal. That phenotype is generally a benign one with low risk for most patients. We still risk stratify them, we look at them the same way, but if you take out the apical HCM patients, they tend to do very well their entire life, low risk for sudden death and low risk for symptom development, the Yamaguchi, so to speak. What Dr. Fuster's raising is a different phenotype. It's when patients develop thinning, akinesis, what we've termed an aneurysm at the apex, often associated with midventricular hypertrophy. It looks like an hourglass shape, the LV. And this phenotype, which is an uncommon one, kind of emerged out of the MRI era because we were able to sort of really relate to the phenotype with MRI, where I think it remained a little bit under the surface with echocardiography, particularly in the pre-contrast era. It's a really uncommon phenotype. It's less than 1 or 2% of the total HCM patients develop the aneurysm, at least based on the current understanding. But with that, what we've done is tried to describe what happens. And, I have to say that, my feeling is that it's a high-risk subgroup. That aneurysm is scarred. These patients are at an increased risk for ventricular arrhythmias greater than most other HCM patients and similar to other high-risk HCM patients on the order of about 4 to 5% per year risk of VT. And also are at risk for clot to form in the aneurysm and thromboembolic events. So we take a position, actually, based on that data, that we are aggressive with these patients in generally considering them for primary prevention therapy with ICD and anticoagulation. That said, like everything in HCM, when you have really small numbers, precisely defining risk is often hard. But I think that we know enough now that those are reasonable considerations for most patients with apical aneurysm. Of course, you have to individualize it. If it happens to be an older patient, they may be in some ways lower risk because they've achieved advanced age with the aneurysm. But that's our general strategy with those patients.
We're 5% of your patients.
Right, sudden death event. So we define that as those that suffered a sudden death event, appropriate ICD shock, because we've been putting in defibrillators in these patients now for a while, or out of hospital arrest. That event rate is about 5% per year.
I'm sorry, I mentioned apical hypertrophy. It's not apical hypertrophy.
Yeah, it's aneurysm. Yeah, it's just aneurysm, right?
Yeah.
Can I ask a question?
David, we have an issue here, and most of these patients have chest pain. And I think you escape in your manuscript to really get into it. But I can tell you there are a couple of papers that came to Jack pointing out, and I'm not sure it is correct, that when the hypertrophic ventricle contracts, sends a wave backwards. And therefore, what you have is like a stilling phenomenon. And this is like the Bispherians pulse. The first squeeze and the second one. And that leads to the ischemic phenomena. And then you may address this with different technologies. This has been done actually with Dopplers and actually MR. Are you aware of that?
Not familiar as much with that mechanism. traditional mechanism has usually been just kind of damage to the microvasculature, but rather than the functional effect that you describe. I wonder if they could study that with some of these IFR or coronary lactate levels or some of these techniques we've seen in other diseases. I wonder if there's a way to do that.
I asked the question because I thought the hypertrophy, the microvasculature, but the data that is evolving, and I like your opinion, Martin, the data that is evolving is a very dynamic process, apparently, about myocardial reserve.
Yeah, I mean, I'm not sure I know about that example you just raised. I mean, I think the feeling or the understanding, I think right now, for the most part, is what you were just saying, Dave, is that it's an abnormal microvasculature, extremely abnormal. The intramural coronaries in HCM are significantly abnormal. They have small lumen. They don't vasodilate well for that reason. They get burst of small vessel ischemia, which we think over time causes ultimately cell death and replacement scar. That's where the replacement fibrosis, for the most part, probably comes from. These abnormal intramurals are probably also compressed because of the hypertrophy as well. And that's probably the mechanism of chest pain, which is really common in HCM. And there's some evidence to suggest that that's true as well from imaging. PET and cardiac PET and stress CMR have all shown that, at baseline, myocardial blood flow is normal in HCM, but you add stress and it becomes markedly abnormal in this disease. And so I think that kind of ties together probably this pathophysiologic cascade of small vessel ischemia causing chest pain. It can often be very difficult to treat. You may have patients that have a lot of chest pain with HCM, and I think high dose verapamil may be the best choice, and we sometimes use unconventional things like ranolazine or Ranexa in HCM with some success as well.
Okay. Let me see. Donna, I'm going to ask you a question. We are entering now into risk stratification and management. And management was not part of the discussion today, but I'd like to get into it. I present to you 6 cases in less than 1 minute, okay? The patient has IHSS, has hypertrophic cardiomyopathy. That's not the issue. The diagnosis is clear. Patient number 1 presents with syncope. Patient number 2 presents with several episodes of non-sustained ventricular tachycardia. The patient number 3 presents with exertional drop in blood pressure. The patient number 4 has a family history of sudden death. And the patient number 5 has an MRI of gadolinium of more than 15% of the ventricle being affected. This is my question. Are you going to put an ICD in each of these individuals that I mentioned? Or you are going to wait for 2 factors, 3 factors? And I'd like to ask this question to the rest of the group here, because these are the so-called risk factors for sudden death.
What was discussed earlier today was that one risk factor per se, you don't have to proceed with a device. And each of these patients has one risk factor. The last person has the fibrosis, which not clearly is grouped into the traditional risk factors. I would look at the whole picture, and I know that there's controversy about the impact of knowing what the genetic mutation is, but there have been some genetic mutations that are more associated with sudden death. So I think if I had someone who had syncope and had one of these high-risk mutations, I would favor putting in a device. I have a very low threshold for putting in devices because I really think that sudden death is a tragedy that we can usually prevent. So I tend to favor being aggressive.
Well, I believe clinical judgment is also critical, but when you have a patient with hypertrophic cardiomyopathy, and one of these 5 factors is very tricky. Martin?
Yeah, I mean, that's the thing. I mean, risk stratification is really in an uncommon, complex disease like this really challenging. I think what Donna was saying is true, and what's emerged out of the last couple decades is the principle that of the traditional 5 non-invasive risk markers, massive hypertrophy, abnormal blood pressure, NSVT, multiple NSVT, syncope, and a family history of HCM, that I think what we know is that one risk factor, two risk factors certainly puts a patient in a high risk category. There's little doubt there. But one, as we were just saying, may be enough. And that is particularly the case when you're talking about massive hypertrophy, unexplained syncope, or a family history of HCM in a close relative. Those are the 3 strongest predictive non-invasive markers we have. That doesn't mean that every single patient that has that one risk marker, of course, gets a device, and you have to put it all together. The age of the patient, and by the way, that's really important. We've demonstrated that age matters in HCM as well. It's an anti-risk factor. If you achieve the age of 60 with HCM or beyond, risk of sudden death is actually really low, even when you've got one or more of those other markers. So age is important. It matters, in addition to putting the whole clinical profile together. Extensive LGE, the newest of the markers, and perhaps the strongest, although it's comparing them, the different risk markers, is challenging. But I'll say the preliminary evidence is that a lot of scar may be the strongest of all of them. And so that falls into the one risk factor category potentially as well, once you've put it all together. And I'll tell you that even when you put it all together, that it's sometimes you come out with a gray area, as I was talking about this morning, where, being absolutely sure whether the patient's in a high enough risk category to deliver or recommend ICD may still be somewhat uncertain. And that's why you have to do a shared decision-making strategy sometimes. I mean, that's the only way.
I guess age is important, though, because most of the sudden deaths are under the age of 40.
Yeah, I mean, those risk markers that we're talking about are most applicable to young and middle-aged patients.
Yeah. Mark Miller, I hope you're awake. Just be ready. Okay, first of all, would you do a Holter or would you put a device link on anybody who has significant hypertrophic cardiomyopathy? That's question number 1.
I think I would put a defibrillator. No, I'm just kidding. The question is, first of all, just in regards to that first patient, you mentioned the apical aneurysm. I agree with Dr. Maron. I think apical aneurysm, at least the data would suggest, it is the highest risk category, with risk of sudden death in the high teens. And so I think anyone with aneurysm, especially by MRI, should probably get a defibrillator, which is obviously different than apical HOCM variant. I don't tend to use, you mentioned all the major risk factors, I don't tend to use that anymore. I don't use one major, one minor. I tend to use the ESC criteria for a couple of reasons. Is you can plug in the numbers, and it has relatively good discriminatory power, but it gives you a percentage that you can discuss with the patient of their risk over 5 years, and I think that's pretty powerful. Years ago when I was using the one major, one minor, then you have a discussion with the patient, whereas if they see an actual number of their risk of an event over 5 years, I think they can swallow that idea more, and if they need a defibrillator, they're more willing, and if they're low risk category, then they feel more comfortable knowing that their risk is such and such over 5 years. Regards to your question about the NSVT, I mean, most of the data we have from NSVT is based on Holter data. So over 24 hours, that time point they did a Holter. If there was NSVT, it was a risk factor for sudden death. And I know that a lot of people here, including myself, are big fans of loop recorders and putting them in, but I don't know, for example, how sensitive or specific you are when you're monitoring someone for 50 weeks on end. If you're monitoring them for an entire year and they have one episode of NSVT, is that the same category as someone who had that one NSVT during a 24-hour period? I don't think we have data on that. I just want to make one more comment. All the data on outcome, most of the data on outcomes for risk of sudden death also includes ICD therapies. And I think years ago when devices were being implanted or when devices were going in, the programming was very short. And so patients could have an ICD therapy, whereas for nowadays conventional programming, they might not have had a therapy. It would be considered a non-sustained event. So I think that has to be taken into account. ICD shocks are not necessarily the equivalent of sudden death.
Martin, I think you guys have changed your mind. If I recall, you didn't pay too much attention to arrhythmia. Sometime about 5 years ago. Then you talk about recurrence of non-SVT, non-sustained ventricular tachycardia, which means clinically the patient is having episodes. But in your last few articles, I begin to read that you like to do Holter monitorings on everybody who has hypertrophic cardiomyopathy. Is not correct?
Well, we do Holter monitoring, 24 to 48 hour Holter monitoring on almost all patients initially. If they're young or middle-aged, we may not do it if they're, greater than 60 because, again, as I said, the risk of sudden death in that group is really low. And we will do that as part of the risk stratification because, obviously, multiple runs of NSVT may identify increased risk for that patient. And we will repeat the monitoring and the imaging on a yearly basis for risk stratification to be done annually, at least for young patients, for sure. So we not only do it initially, but we'll do it at least on the annual visit.
Another question, and I asked this morning, I think it's important to ask because it has been a driving force by the Mayo Group of operating people with high gradients and being asymptomatic. It seems you are not convinced about it. Let's say a patient is asymptomatic, a gradient of 90 millimeters of mercury, 120. The Mayo people feel very much strong that the data, they suggest that this increases mortality. Do you agree with that?
Well, no. I mean,
all right.
I don't. I mean, I think that, no, because I don't think we have really the evidence to support the idea that just because you have high gradients and you're asymptomatic, that portends necessarily increased risk of death. Okay. Now, sudden death, that patient has to be risk stratified for sudden death. When we're talking about high gradients, we're talking about progressive limiting heart failure. Okay. And so what I was saying this morning is that I don't have any evidence to tell a patient that we should do a low risk but not a no risk operation like a myectomy to relieve obstruction if they're asymptomatic and that would in any way alter their natural history versus waiting until that patient became symptomatic. And by the way, that patient may never become symptomatic.
But someone who develops a gradient of 120 when they exercise, don't they have a reduced exercise capacity?
Sometimes they don't. I mean, sometimes, it's remarkable, but sometimes they don't. They have a very good exercise tolerance on the exercise echo, and they don't give any indication on a history that they're limited by symptoms.
So if you looked at their predicted maximum, it would be
it may be abnormal, but it may be. So if you did a VO2, it may be abnormal. It probably would be abnormal. But if the patient is otherwise on a day-to-day basis not limited by dyspnea or any other symptoms, and in fact tell you that their quality of life is good, they're happy, then we don't have any evidence that you should operate on them just because the VO2 is diminished.
But do you know if they're really doing stuff?
Well, I mean, I think we spend, I think that gets into, really trying to be as thoughtful as you can about really pressing patients about their history and whether or not they're really limited or not. I mean, and if, by the way, if you're not sure or there's some ambiguity, we occasionally will use VO2 to help arbitrate that decision. But most patients, we're talking about generally pretty young patients. We ask them, are you still working? Are you, we really make sure that we don't feel that the disease, in this case the gradient, is impacting their lifestyle.
So I have a question. It seems to me, if I summarize what I hear, in hypertrophic cardiomyopathy, you use medications or septectomy or alcohol ablation and so forth, only for the relief of symptoms. If you want to prevent death, you use an ICD. Is this correct?
That's correct. Yes, that is correct.
Okay, guys, so no procedures to prolong life, just to improve quality of life.
Yep.
Dr. Brewster, can I add one point? So one of the studies that came out a few years ago was looking at gradient versus exercise capacity in the HCM population, and it showed that if patients achieve 100% or more of their age-predicted Mets, the outcomes were extremely good, so less than 1% event rate, compared to, there was no, it was a better predictive measure than looking at gradients.
I have to confess that the reason why the Mayo Group came into this is because they have patients with exercise, high gradients, they drop blood pressure. They think this is a great risk, and they do septectomy, they do myectomy. That's for that risk factor, because they say to put an ICD when you're dealing with a risk factor that is mechanical, it doesn't make much sense. I'm just giving you the sense of an institution that I have been dealing with this disease.
Yeah, I mean, just to be clear, I mean, you know, what has been looked at is the relationship between obstruction and sudden death, okay? And there is a very weak relationship between those two. So that means that the rationale, and that's, by the way, why obstruction, even high gradients, are not a risk factor in the guidelines.
I understand it.
Right.
Yeah.
So that there, for that reason, you know, no really clear rationale to operate just to reduce sudden death risk for that reason.
It.
Yeah.
Mark, atrial fibrillation in this entity, is ablation successful or very difficult?
It's not nearly as successful as it is in the regular paroxysmal or persistent patient population. Very difficult to get transmural lesions in these patients. They tend to have a lot of non-PV substrate. So I think all of them should be anticoagulated, but you can't quote them the same numbers as for regular paroxysmal. I have one question regarding that ICD question. So I had sat on a panel with Dr. Maron's father about 2 years ago, and one of the issues that came up with is that one of the reasons that we're hesitant, we know these patients have sudden death. If you're 25 years old and your septum is 20 and you've never had syncope, you're at risk for sudden death. So is the reason we're not putting in defibrillators because of the cost, or is it because of the procedural aspects itself, that a 20-year-old is going to have to live with a defibrillator for the next 50 years of his life? And if that's the reason, do we think that these non-indwelling defibrillators will have changed the equation as it relates to sudden risk, prevention or sudden death prevention? Meaning, why not if someone's young and has hypertrophic cardiomyopathy that normally you wouldn't put in an ICD, but you believe they're at risk, a subcutaneous ICD would seem like a low price to pay. The patient's not going to be at long-term risk.
Martin?
Well, I mean, I think, part of the answer to that is that, I think that with all that we know, we have defined a low-risk profile in HCM, okay? One in which, the absence of any of those markers defines essentially a patient whose risk of sudden death, perhaps with HCM, would be almost no different than the general population, or at least has a high likelihood to achieve normal life expectancy. So I don't know if I completely agree that with the rationale that we should be looking at anybody with HCM as having increased risk enough to potentially put in a device, even one that would be less impactful than a transvenous ICD. Because I think we define very well low-risk patients today because of the current contemporary risk stratification. And that's why I was saying this morning, just because we have the sub-Q device, in my view, doesn't lower my threshold for recommending ICD. I still base it on the ACC-AHA non-invasive risk markers. It may, if that patient is high risk and I think they need a device, may prevent ICD complications, which is a good thing, but I don't think it changes the threshold.
Two last questions. Amy, are you excited when we send a patient to you with IHSS to look at the genetics? You don't appear too excited, according to my experience.
I think it's a good opportunity. I mean, there's so much that can be gleaned from that visit. So we talked about family history. It's not enough to just ask if the patients have a family history of HCM or sudden cardiac death. It's an opportunity to probe into mysterious death, drowning, unexplained car accident where their relative was the driver. Those are clues that there could be cases that are in the family that have not been identified yet.
But Martin, it's like flipping a coin a little bit. If you're lucky, you will get something, and then you can look at the next generation, whether they have that gene or not that gene, or maybe they are phenotype negative and genetic positive, and probably means nothing. So,
exactly. I mean, I think that So first, the hope was that genetic testing would allow you to have some kind of prognostic ability in HCM. I think that, in large part, has been shown not to be the deal. So we don't use mutations to affect outcome. And so the benefit of genetic testing really relies in family assessment, identifying whether kids or relatives are at risk of developing HCM if they have the pathogenic mutation. And of course, that issue is also not without complication, because if you have a patient that you test and they have the gene but they have no LVH, then there's the possibility that that patient may never develop hypertrophic cardiomyopathy, but yet is subjected to some adverse issues related to insurance and things like that. So there are complications.
The son or daughter of that patient might develop it, though.
That's right. That's
the
right. So
problem.
life and disability, that's a problem. They get labeled in the eyes of lots of people as having disease, even though they may never develop clinical evidence of hypertrophic cardiomyopathy. In fact, we're actually recognizing more and more older patients with HCM who are carriers, this is through family testing, who have no evidence for HCM, again, suggesting that this idea that that's always a highly penetrant deal may not be true.
Right. David, this is the last question. I personally think is wrong. You might think is right. I have a patient with hypertrophic cardiomyopathy, quite vital, under age of 60. Cannot, exertionally speaking, is very symptomatic. I think that in that guy, he's so vital and so good, to do alcohol ablation is a mistake. And the reason I'm saying is because he has a 30% chance of ending up with a pacemaker. On the other hand, if I have an 80-year-old with a stumbling around, I think to do alcohol ablation is quite appropriate. I'd just like you to react to that.
Well, I think there are a lot of advantages to surgery, and usually the disadvantage is either the complications or the vitality of the patient, ability to recover. So I think with most options, especially in this disease, if we have the option for surgical intervention, then as we mentioned before, there are options to affect the mitral valve or the submitral apparatus. There's more direct visualization and lower rates of pacemaker. So in a vital patient who can tolerate a surgery who's very symptomatic, I agree with that. And I think we should reserve some of the percutaneous approaches for patients we have more limitations, or there's no other indication we can see on imaging non-invasively that would require more of a surgical fix.
Martin?
Yeah, I mean, I think I'll echo that. I think that in general, we consider surgery still to be the gold standard therapy for advanced heart failure in the setting of obstructive HCM, because it provides the opportunity to essentially abolish the gradient in a complete way and may provide a little bit better symptom relief with less risk for pacemaker and almost no risk for repeat procedure rate. So we recommend surgery in younger, middle-aged patients for that reason as the first option. For those that don't want to have surgery or have increased risks that would increase surgical risk with comorbidities, have a fear of surgery, or are older patients, alcohol ablation is a great alternative option.
You have 6 cases, or your father has 6 cases of mitral valve plication, as we do the clipping.
Right.
And with good results, it seems to me, in taking care of the obstruction. Is this a possibility?
Yeah, so mitral valve clip, there's been a number of case reports. The largest you're talking about is about 6 patients that has basically essentially, stabilized the anterior leaflet so it doesn't bend in and cause obstruction in patients that were not candidates for surgery or ablation. I think it's really early and it's hard to know who the right patient for that procedure would be, and based on anatomy and other issues. So I think we're learning more and more, but there's the possibility that may be another option for some patients.
Okay, thank you. Any questions? We have about 2, 3, 4 minutes. Questions about the topic? Yeah, Roger.
So, thank you for this discussion. I mean, we obviously discussed this before. One of the most disappointing things to us in sort of basic science community is that genetically, there's so little predictive value in the patient's outcome. And that's kind of been, a sore point for many researchers in the field that, there's so little known. I mean, there's so little information gained by the genetic testing in terms of overall patient's outcome. However, as we, discussed recently, is that those same genetic mutations are giving information at the molecular level where new molecular small molecules are being designed to target those abnormalities. Clearly, Cricket-Seidman's work on the myosin decouplers. So it'll be great to have your input on that. And of course, I have my own opinions, obviously, that we discussed.
Yeah, so Roger's raising, for those that you may not be familiar with, there's a company that's produced a small molecule drug that's a myosin inhibitor, decouples at the myofilament level. So you basically get less cross-bridging in hypertrophic cardiomyopathy because of this drug, so less myosin-actin interaction. And essentially, what that drug does is that by doing that, it's a negative inotrope effect. It decreases systolic function. Whether it has other properties that relate to diastolic function, I think are a little bit unclear, but what it definitely does is it decreases myocardial contractility through this mechanism. And I think that to make a long story short, it's in clinical trial development right now. It's about to enter phase 3 studies. And I think, I'll just say it's exciting that there are drug companies that are having an active interest in developing new drugs for HCM. I'll remind everybody that we still use beta blockers, calcium channel blockers in this disease as the primary drug therapy that were introduced, beta blockers, by Brunwald in 1960 for HCM. So we need new therapies. There's no question about that. What will happen with this drug, I don't know. It's being used because it's a negative inotrope to decrease obstruction, lower gradients, and if you lower gradients, that will make people feel better. Whether that can be achieved, with a drug in a clinical environment is yet to be unknown. And I think that we'll learn a lot more with the phase 3 study, which is, I think, starting soon. So maybe there'll be some promise for another drug to help treat heart failure due to obstruction with this drug. But again, there are a lot of questions about efficacy and safety that remain unknown at the moment.
Just for completeness, I think we were going to discuss this, but there's no time. You're talking about the Liberty HCM trial, eclosin, which actually affects the sodium channel. And then there is the other trial going, this that I'm aware of.
Yeah, so that's a different trial. That was a
the
study.
HALT HCM trial, which is targeting oxidative stress. What he's talking about is whether you target the molecules that are the result of the genetic problem,
right,
rather than being obsessed by the genetics. That's the issue.
Correct.
Yeah. Good. Any other question? Yes.
Is there a therapeutic hierarchy and choice of drugs to handle obstruction and maybe at the same time handle arrhythmias? We have beta blockers, we have disopyramide, we have calcium channel. How do you handle this?
Yeah, so if you have an obstructed patient who is asymptomatic completely, and again, I go by clinical history, there may be no role for drug therapy at all at that point. We have a lot of patients with obstructive HCM, even with high gradients, who may not be on any AV nodal blocking or any drug therapy at all. There's a theoretical benefit of giving a beta blocker in an asymptomatic patient by lowering gradients, but whether that actually changes the natural history of that patient is unclear. If you've got a symptomatic patient with obstruction, generally the first choice is beta blocker. And then we kind of go up on the dosing and see how they do clinically, if they get better or not. And we judge that by, really their quality of life, how they view that. If that doesn't work or they have side effects, you can sometimes try calcium channel blocker therapy, but that's pretty weak negative inotrope, and so it's often not effective. The only other drug therapy currently available in that situation would then be disopyramide, which is an antiarrhythmic drug, but we're using it here for its negative inotropic effects. But it can be difficult to use because of side effects, parasympathetic side effects, and really limited long-term efficacy. So in that situation, then, at that point, you're really on to invasive options then.
Do you use combinations of these?
Well, I mean, you can, but I don't think there's any clear evidence that combining beta blocker and calcium channel blocker, for example, is synergistic or provide that much or any clear improvement over one agent.
Are you implying that the verapamil is not a good negative inotrope?
Well, not a negative enough in this issue to cause enough of a lowering of the gradient to make a clinical improvement. Yes, that's what I'm saying.
Thank you.
Yeah.
Okay, well, we have enough about hypertrophic cardiomyopathy. Thank you. Thank you very much to all of you. Thank you.